Dr. Felice Gersh, your integrative OBGYN physician. Now, one thing that really is making me smile is that menopause is suddenly so trendy. Now, I have been treating women in menopause for several decades, and I lived through the whole Women's Health Initiative and the craziness that followed when it shut down everything. When it shut down, and it shut down hormones for so many women back in 2003. We're talking a long time ago. And I fought for women. I begged my patients to stay on hormones. I said, this is irrational, it's unscientific, there is no way that this study will be upheld or revered. It's going to be reviled. Just give it some time. About half my patients stayed on hormones, and the other half were so fearful by all the ridiculous rhetoric that came out about all the evilness of hormones. Well, let's fast forward to today. I just said I smile because menopause is trendy, and in a good way. It's now being promoted to recognize that menopause is the beginning of a huge, and perimenopause, all of these transitions in terms of loss of ovarian hormone production, is now recognized more and more widely that it is the beginning of a huge metabolic shift in women. Not only is reproductive functions, are they lost, but metabolic health starts to take a gigantic hit. And metabolism is life itself. It's the production, distribution, utilization, storage of energy, which has to do with everything, every organ system. So the bottom line is menopause is now being more widely acknowledged. I have to admit, not in every little crevice and corner of the US or even the world, but more and more that menopause is natural, but not beneficial to women. So I'm thrilled with that. But then comes the nitty-gritty. What do I mean by that? Okay, if hormones are now recognized as good, then, and menopause essentially is harmful to women, it's definitely a new chapter of life, and we want to make the best of it, and we want to have a wonderful many years spent in menopause. In fact, many women spend half their lives as menopausal women. We want to make them wonderful years, happy years, productive years. And recognizing the issues that women face when they lose these vital life hormones, estradiol and progesterone, is the first step. It's not the last step. That's the problem. As more and more it becomes universally acknowledged that menopause is harmful, then the question is, what do we do about it? So it's now being more promoted, and this makes me very happy, that hormones are good. The exact opposite of what was said about hormones when the Women's Health Initiative came out, which was basically hormones are evil and harmful and will give you higher risks of cancer if you take them, heart attacks, strokes, dementia, everything bad you can think of. So now that is being refuted. Hooray! But here's the problem. The legacy of the Women's Health Initiative will not go away. And what legacy am I talking about? The mantra that came out of the Women's Health Initiative, which was, if you do decide to use hormone therapy, use the smallest dose of estradiol or estrogen. They didn't even say what kind of estrogen. It was the smallest dose. They didn't even go into progesterone at that time. So we're just going to talk about estrogen for this one. There's so many more things we're going to talk about. But for this particular Instagram, we're going to talk about estradiol or estrogen. So the mantra that came out of the Women's Health Initiative was that if you're going to use estrogen, you should use the smallest dose for the shortest amount of time. That is one of the biggest legacies, evil legacies, of the Women's Health Initiative, because that will not seem to go away. And I'll tell you why I think that is in a moment. So the smallest dose To do what? What would you use the smallest dose for? Why would you use hormones at all? Why would you take estrogen if at that time, and you believed the ridiculousness of the conclusions of the Women's Health Initiative that hormones are so dangerous, if you believe that and then you transferred it to bioidentical hormones, because it is true that Premarin is certainly far from an ideal choice for estrogen. That's conjugated equine estrogens. That's what was used in the Women's Health Initiative. They didn't have to use it. There was transdermal estrogen. There were patches at that time and had been for years. But they chose to use Premarin, conjugated equine estrogen. And that we now know. We knew it a lot then, too. It's not like we didn't know it. I knew this. If I knew it, everybody could know it. That it increased the risk of clotting tremendously. Turns out like 400%. That's not a good thing. We don't want random clotting happening at a higher risk of 400%. And what about the pretend progesterone, the progestin, medroxyprogesterone acetate? Well, it turns out that that is bad, bad, bad. It blocks the production of critical nitric oxide. It actually increases the risk of breast cancer and dementia and heart disease. So that was bad. So the conclusions of the Women's Health Initiative, which were actually well outside the boundaries of what should have been concluded, at least initially, only applied to what they studied. But that's not where it was left. It was left with all hormones. Doesn't matter if they're bioidentical, doesn't matter anything. It doesn't matter. They're all evil. So if something is deemed evil and harmful, but somehow or other you feel you need to use it because you have unbelievably horrible night sweats and hot flashes, then they said, if you feel you absolutely must use these hormones, estrogen, then you should use the absolute smallest dose to achieve the goal of reduction of night sweats and hot flashes. And then you would only use it for the shortest amount of time because you want to get rid of it because it was deemed evil and dangerous. Well, unfortunately, that, as I said, that legacy lives on, that mantra of the smallest dose. And the idea that you only give hormones to do what? To accomplish what? Well, the FDA has approved hormones for only a very few things. Vaginal hormones, estrogen, for the purpose of genitourinary syndrome problems like vaginal atrophy and bladder issues, and systemic, that means body-wide hormones, for only two things are FDA approved: to reduce the development of osteoporosis, although it's almost never used that way in the common world of conventional medicine, and the one that's always used and has been promoted since the Women's Health Initiative, which is suppression of night sweats and hot flashes. So it turns out that the amount of estrogen, I'm going to say estrogen because people use oral estrogen for this purpose. I don't. I use only transdermal through the skin estrogen in the form of estradiol. But for the moment, I'm just going to say estrogen. That's the family of hormones of estrogen. So that is what people have been using hormones for, estradiol, for that FDA-approved use of suppression of night sweats and hot flashes. Well, it turns out, this is a blessing and a curse from my perspective. The amount of estrogen you need to suppress night sweats and hot flashes is minute. It's almost like a whiff. Many of the original estrogen formulations that came out many years ago, when they measured levels in the blood, because that's the gold standard, measuring the level of estradiol in the blood, these were transdermal, early transdermal products, and they came in the form of gels and creams and patches and sprays. When they measured the levels, they were typically really, really low, often in the same general range of estradiol level that you would see in a menopausal woman on no hormones. But yet, if they continued the use of these estrogen products, sometimes out 12 weeks, there was a statistical reduction in the incidence of night sweats and hot flashes. So most of the products that got FDA approved for commercial use, including the bioidentical gels, creams, lotions, sprays, patches, they included incredibly low doses of estradiol in them. Okay, really, really low doses. When it came to the conjugated equine estrogen, Premarin, the lower doses, the 0.45 milligrams and the 0.3 milligrams, often became the most commonly used of that type of estrogen product. So the mantra of the lowest dose became just implanted in the brains of doctors, practitioners of all sorts, and patients, because this fear of hormones was so, and still is. I can't seem to get rid of it in so many ways. I keep trying. But this fear of hormones, that somehow you always have to worry about them. In fact, you hear this all the time. When you prescribe hormones, make sure you consider the risks versus the benefits. And I say, what the heck are the risks? Breast tenderness, irregular bleeding, sometimes fluid retention, or any of those life-threatening? Absolutely not. Because there's such a confusion between the different estrogen products. You know, the oral estrogens, which do increase blood clotting, and they are pro-inflammatory because they are predominantly estrone, and then the transdermal estradiol products, which they're basically cousins, but they're not the same, and they have different effects, and that it gets all forgotten, all mixed up. So, fast forward once again, back to today. This mantra of the lowest dose to suppress night sweats and hot flashes for symptom reduction remains the standard of care. Now, why do I disagree with that? Because that's not the only reason that I prescribe hormone therapy. And by the way, more and more doctors are prescribing hormone therapy off-label, totally legal. It doesn't matter that the FDA has not approved estrogen in the form of estradiol for a lot of things that we know it can do, because it's not illegal and it's totally fine. Many, many drugs are used off-label, commonly, very commonly used off-label. So the bottom line is, if you believe, as many of us do, that hormones are not optional for optimization of every organ system functioning, then you have to recognize the following. Dose matters. Once you get over that hormones are dangerous, and I'll say estrogen, let's just go to estrogen for now. And then I'm going to say estradiol, because that is what is most commonly used transdermally through the skin, transdermal estradiol. Once you accept, which is true, that estradiol is incredibly beneficial and incredibly safe to use, really safe and really beneficial, then what kind of dose do you want? The smallest dose? Or how about this? The optimal dose. If something is good for you, why would you want the smallest dose? Let's think of things that are good for you. Remember, bioidentical hormones are good for you. Okay, get over the fear. Nothing to be afraid of. Okay, so they're good for you. What else is good for you? How about exercise? Okay, would any rational person say, I'm a trainer. I recommend that you exercise the bare minimum to survive and be capable of walking across a room. So I recommend that you exercise very marginally 5 minutes a month. I'm a trainer. I'm expert in exercise and fitness, and I recommend the lowest amount possible. You'd say, what on earth? Well, how about a nutritionist who says, I'm a nutritionist. I'm an expert in nutrition and food, so this is what I'm going to recommend for you. I want you to eat the smallest amount of vegetables that you can survive on. So how about one bite of a vegetable once a month? That's it. Once a month, one bite of vegetables. There you go. You'll survive. You may not be optimally healthy, but you'll survive. Okay, You'd say, what kind of a nutritionist is that? 1 bite of a vegetable once a month? What kind of a trainer is that? 5 minutes of exercise at a low level once a month? Well, what kind of a doctor am I if I say, I want you to have something that's wonderful for you, but I want you to have the absolute smallest amount? What? I want the optimal amount of everything that's good for me. I want the optimal amount of sleep, of fitness, of happiness, of great food, and I want the optimal amount of estradiol. Now, how would we know? Let's say we now accept that minimal dosing is irrational if optimal health is your goal. If your only goal is suppression of night sweats and hot flashes, which takes hardly any estradiol, then fine. If that's your goal, you have to decide, if you go on hormones, what's your end game? Why are you going on them? Is it for optimization of global health in your body or suppression of night sweats and hot flashes, which I do not minimize the importance of, because not getting adequate sleep and having night sweats and hot flashes, we know is bad for your cardiovascular system, for your mental health. So I'm not minimizing the benefit. I'm just saying, why are we stopping there? It takes a lot more estradiol to grow bone and optimize brain health, optimize vascular health, than the amount it takes to suppress night sweats and hot flashes. The amount for basic survival is not the same as the amount for optimization. Now, how would we know what an optimal dose is? How would we know? We have to go to the menstrual cycle. Now, a healthy group of women, like say 10 healthy, fertile, reproductively successful women, they don't all have the exact same levels of estradiol. Even if they all 10 of them have 28-day cycles. It doesn't mean that on the exact same day of the cycle, of the 28-day cycle, they have identical levels of estradiol. There actually is a significant range of normals. So what's my goal when I treat my patients? I want to be in the range of normal, okay? And then I'm going to average it out so that it's approximately in a good range throughout the whole time, all the time. Now, there's a lot of things on the horizon that I'm really doing a lot of research on, and that is, should we give a different dose of estradiol when you're not on and when you are on progesterone? We're going to talk more about that another time. But for now, I just want the very basic concept of optimal dose is not the same as the lowest dose in anything that's good for you. We know that the amount of estrogen to grow bone is different than the amount to simply suppress night sweats and hot flashes. The amount to optimize your brain is different. The amount to optimize your immune system is different. The amount to optimize everything, your gut health, okay? I mentioned your brain, your vascular health, your skin. Nothing is the same as the lowest dose. Now, I think that it's really important that you know that the amount of estradiol does impact how the immune system works. This is really important. Now, how do we know this? We know that low levels of estradiol, not zero, but low levels, are actually more pro-inflammatory. And you don't want to be in a pro-inflammatory state all the time. That is really harmful. And high levels of estradiol are more anti-inflammatory. So where does this information come from? Once again, the menstrual cycle. In a menstrual cycle, when is the situation most pro-inflammatory? When the woman is bleeding during the period. Now, what's the estradiol level during a period? It's really low. It could be definitely in menopausal level range. It's really low. And why is that? Why would nature want that? Because when you're having a period, it's a pro-inflammatory state. You're actually shedding out dead and dying lining tissue from your uterus. And that is an inflammatory process. Actually, pro-inflammatory prostaglandins are produced in the uterine cavity, which causes some cramping. Too much cramping shows you have too much inflammation. and it helps to push out that lining, and it's a pro-inflammatory state. Now, when is it the most anti-inflammatory in the menstrual cycle? When you have preceding ovulation, you have a giant spike of estradiol, and that will trigger an LH spike, which then triggers ovulation. Well, what's happening in the body that you would want to have a lower amount of inflammation? You want to be anti-inflammatory. Well, you have sperm coming in, and then you're creating an embryo. You do not want your immune system to be in a pro-inflammatory attack mode to attack the sperm. Remember, they're aliens. They do not have the same DNA. They have different antigens than your own. So they're an alien coming in. And the immune system is designed to attack aliens, whether they're pathogens or sperm. In fact, sometimes that actually happens. That's a problem with some fertility situations. So the immune system is down-regulated when you are about to ovulate, and you have that big spike of estradiol so that you do not kill the sperm that are coming in. So high levels of estradiol are anti-inflammatory, whereas very low levels are pro-inflammatory. When we give the lowest dose of estradiol, and I'm going to talk about some of the doses, when we give the lowest dose, that can still suppress night sweats and hot flashes, but it's in a pro-inflammatory level, we don't really know because we don't have enough data. Are we doing harm long-term, or are we doing beneficial stuff? We don't even know. But many women now in menopause, I'm not going to talk about perimenopause, that's a whole different thing, but we'll talk about menopause where the ovaries are not producing any estrogen anymore. They're being given the very tiniest doses of bioidentical estradiol that exist. We're going to leave the Premarin out of this for now because most women are now on transdermal. And if they get the Premarin, they're often put on very small doses too. But let's talk about transdermal. So with the patches, the lowest dose patch is 0.025 milligrams. Many women are started on that dose. If you measure the estradiol level that you get, it's so low, it's like always in the menopausal range. It's like, what are you accomplishing? You're accomplishing something. You're reducing or eliminating night sweats and hot flashes over time for most. And you're doing some other things. I don't want to say you're doing nothing. We do know that even a little bit of estrogen, very, very small amounts, can help suppress bone loss. It won't cause bone growth. It's not going to be optimal for the immune system, but it can reduce bone loss and it can reduce night sweats and hot flashes. So I don't want to say negative things too much. It is still beneficial in that regard, but that's not an optimal physiologic level. So in order to get a level that is most compatible with bone growth and optimization, you need to get up to the full strength 0.1 milligram estradiol patch in menopause. Now, I'm not saying everyone should be on that dose, but most women will probably benefit the most from that dose. Now, there was an interesting study that showed when they took women had no estrogen, their arteries were constricted. They tested with a study type of device called a flow-mediated dilation. No estradiol, none at all, the arteries were constricted. They gave a 0.1 milligram estradiol patch and the arteries dilated, okay? Now, we're going to talk about this another time, but in that study, they then gave 200 milligrams of oral progesterone and the artery constricted again, okay? That is worrisome, okay? So that's why I'm saying that we will talk about this in the future, how to give progesterone, whether we should give it orally or some other way of delivery, and what happens when you add progesterone, should you consider increasing the level of estradiol. We'll talk about that. But for now, recognize that progesterone downregulates estrogen receptors. So if a woman is on everyday progesterone orally, which I talk against all the time, they're actually then downregulating the effect of estradiol that you have on its receptor. So you're effectively downregulating the dose even more. So what are you trying to do? Why would somebody do that? Because they want to suppress growth factors. They don't want the uterine lining to grow. The problem is if you suppress the growth factors by giving nightly progesterone and you give a very tiny dose of estrogen, like a 0.025, 0.0375 estradiol patch, you're not going to get growth factors. The idea is don't grow the uterine lining. We don't want to have bleeding. The problem is growth factors are what grow bone, that renew and restore and rejuvenate your neurons in your brain. That's how you get brain-derived neurotrophic factor and nerve growth factor. You want to have VEGF, vascular endothelial growth factor, so you can grow new blood vessels. You want to have tissue growth factors so that you can repair and grow new tissues. You need growth factors. Growth factors require an optimized dose of estradiol. So I talked about that this old mantra of the lowest dose, how it came out with the Women's Health Initiative, because it was based on hormones are dangerous and evil. But once you move beyond that and you realize all the mistakes that were done in that study and the results, how they were interpreted, and you move on from that, then you need to leave that mantra of the lowest dose behind. But it won't be left behind. And the reason is that even doctors who understand that dose matters and that the mantra from the Women's Health Initiative was based on the false misunderstanding that hormones are dangerous, there is such a now pervasive wrong approach to hormone therapy that you need to suppress bleeding by suppressing growth factors in the uterine lining. That is going to suppress growth factors in your bone, in your arteries, in your skin, in your brain. You need growth factors. That's how you replace dead cells, dying cells from your stem cells. You need growth factors to keep your mitochondria optimized, creating energy and controlling cell cycles. You need to have these growth factors. If you give hormones the way they're currently being given, with very, very tiny doses, and for patches that would be typically 0.05 milligrams and less. For the gel, it would typically be 0.5 milligrams and less. And then you have to measure the levels that are achieved on the higher amounts because they may or may not be adequate. So for the gels and the patches, if you're dealing with the bottom, say, 3 doses, they're too low in the vast majority of cases for optimization of growth factors and maintaining proper control of cell cycles and mitochondria. So if you're giving compounded estradiol, it's kind of a free-for-all because we have no data, no published data. So you have to look at levels. But if you want to know levels, it's been shown that if you get a level in the blood that's under 50 picograms per mil, 50 or below, it's not going to stimulate adequate growth factors. For example, on a level that's achieved that's like 50 or below, you will not in any way restore the vagina. And that brings up another thing. If you're giving a systemic or you're receiving a systemic dose of estradiol that is not adequate to maintain vaginal and bladder health, why would you think that level that you're achieving with that dose of estrogen, patch or gel, why would you think it's adequate to maintain anything? If it's not maintaining the vagina and the bladder and you need additional hormones in the genitourinary tract, then it's a reasonably safe assumption that you're not getting an adequate dose to optimize your brain, your bone, your skin, your gut, your arteries, your heart, your immune system, etc. So the takeaway from today's talk is that dose matters. The idea that the smallest dose is the best dose is crazy. The best dose is the optimal biologically compatible dose, one that has been shown in a young menstrually functional woman to be enough to support all of her organ systems properly. Lowest makes no sense. You don't want the lowest amount of exercise, the lowest intake of vegetables, the least amount of sleep to survive. You want optimization. That means optimal dose. That means biologically compatible level with achieving the end result, which is optimizing the function of every organ system in your body, because they all have estrogen receptors. And dose is not insignificant. Low doses of estradiol are pro-inflammatory, high doses are anti-inflammatory. You don't want to give or receive the lowest dose, and you don't want to suppress your receptors with daily progesterone. It is not physiologic. It is not biologically sensible. Dose matters in everything. Let's stop thinking and talking about the lowest dose, and let's reframe the conversation to the optimal dose. And then let's get more studies and data to help us all to know how best to prescribe hormones for optimal healthy aging, because we definitely need more studies and data. But what we have now is still enough to make a decision that lowest is not best.